Hello everyone, my name is Sudipta Barua. I'm an 11th grader from the California Academy of Mathematics and Science in Carson, California. This project focused on building a custom, patient-specific uncertainty framework for ablation target predictions in ventricular tachycardia patients. Now, ventricular tachycardia, or VT, occurs when scarred myocardial tissue creates reentry circuits that offset the ventricle's natural rhythm from the rest of the heart by hundreds of beats per minute, leading to hypotension, chest pain, and eventually death if untreated. Current treatment methods use catheter-based systems to identify ablation targets. However, they rely on deterministic models, producing results from single simulation runs that miss critical ablation sites and have high false positive rates. That leads to repeat procedures, which happen 30 to 50% of the time, and constant physical strain on a patient. I hypothesize that a custom, patient-specific framework using Monte Carlo propagation will outperform its deterministic counterpart by improving precision and reducing the overall false positive rate dramatically. My pipeline aimed to provide confidence scores for all targets, essentially, a first for ventricular tachycardia treatment. Following this pipeline, MRI scar and tissue data was first mapped to a patient-specific mesh utilizing the Marching Cues algorithm. With that mesh, an electrical wavefront was ran using an E-conal equation, stating that the rate a wavefront spreads is inversely proportional to its overall conduction velocity at a specific point. Circuit reentry was also then detected through a multi-criteria system, looking for slow conduction zones, scar intensity labeling, and activated times by target. This was done multiple times, once for a deterministic baseline and multiple more for realizations using Monte Carlo propagation. With all of those realizations, the uncertainty model was able to provide confidence scores to each individual target as intended, all while calculating the number of stable targets, precision, and false positive rates. So in terms of the biggest results, we have precision. MCP improved over the deterministic baseline at every threshold, even by over 40 percentage points at the most clinically relevant. MCP was also able to discriminate or differentiate between true and false positives with a discrimination rate of 0.966 compared to the deterministic classifier's 0.5. Monte Carlo was actually adding real value, not just noise. On average, MCP also flagged 36.8% of the deterministic targets as low confidence, bringing false positives down dramatically. This rate shifted by patients. Ambiguous patients had higher low confidence scores, while the opposite's true about straightforward cases. In their 3D maps, the deterministic model provided binary results that were always considered critical. You can see with the reds and the grays right here, while the MCP model generated maps that had colored gradients, assigning confidence values to each point. Again, what we were trying to do. That value lets a clinician know what points need to be prioritized and how many points extra should be considered based on patient reaction. So, in conclusion, the model stands basically as a strong proof of concept. As models increase in relevance in the clinical space, it's important to make sure we remove their overconfidence and introduce uncertainty in order to increase the true accuracy of procedural outcomes. It's worth considering applying these systems to other conditions, such as ventricular fibrillation, VFib, or premature ventricular contractions, so PVCs, and we can even introduce monodomain equations that allow for ionic handling, making these models even more specific to a patient, so we can get even better results. But from here on out, to take this even further, the next step would be to test using real-world VT outcomes to prove clinical validity. Thank you for listening.